All right, welcome. This is the Florida Rural Health Association's Summer Educational Series. It's my honor to introduce one of today's speakers. Carl is the co-founder and managing principal of Mitigate Partners, a risk management, cost containment, and employee benefits counseling firm, which is a partnership of 22 employee benefit consulting and brokerage firms that allow local management within a collaborative environment with more than 400 years of combined experience. Welcome, Carl.
Thank you, Lois. Great to be here. All right, y'all ready to begin? All right, this folks, we're really excited to be here today. This is such a great story, such as we're going to talk about a courageous employer that took the steps to do this. And I think hopefully for all listening, any rural hospitals, there's a great opportunity for you to do the same type thing. COVID-19 has been a gut punch for many of these hospitals, as we know, and every dollar, every dime, every penny counts. So this is a great way, we think it'll help put some better cash flow in. So I'll get started and introduce everybody. We got Sica, the CEO of the hospital. Lois, Hilton, also Human Resource Director for DeSoto Memorial. And we got Dr. Gross, who's originally the person that introduced us to the group with Epiphany Direct Primary Care. He's a direct primary care physician. My partner in crime, Barry Murphy, and unfortunately, I was stuck with me. I want to say one or two things about this hospital, folks. This is a 4-star CMS hospital. There's 19 in the state of Florida. That's how privileged of company that is. Now, they don't do everything. They don't do cardiovascular. They don't do a lot of things. They don't do deliveries anymore there, but they're an excellent hospital. So just because a hospital is in a rural area, you have to really look at that. And these guys are tremendous. And Dr. Gross will talk about some medical tourism opportunities later. It's 49 beds, and there's 220 employees eligible out of 157 on the plan with 318 belly buttons. So I'm going to start with a video and give y'all some background on the video after it's done.
We are self-funded here at this facility and have been for 30 years. Our premiums kept going up and up and up. We're a small 49-bed hospital, and we realized that we've got to do something.
When we met DeSoto Memorial, their health plan spend was about $2.2 million. We just wrapped up the first year, and the spend was around $990,000. So they saved $1.2 million, or 54%.
It's remarkable how much you can discount the price of something if you know you're going to get paid at the time of service.
What do we eliminate? The middle. We're going direct. That's how you save. It's direct to employer contracting. We negotiated a cash knee replacement price. That hospital was $70 grand. We got it for $25.
Direct primary care, where you just pay $65 a month, and that covers all of your primary care. And sort of the bundled cash payments are 2 prongs of things that we can do to actually reduce the cost of health care. We also have a program that's called the Medical Advocacy Program.
They walk you through the process.
It was kind of blowing my mind when they turned around and said, well, we'll do everything for you.
Getting them to the right doctor for the right quality, lastly, the right price, and at the right time. That's what this is about.
The less we have to spend on plan, the more we're able to put back into salaries, back into maybe additional benefits or increasing benefits.
It's medical expense per employee per year. We met them, it was almost $14,000 per employee per year. It's now right around $6,000.
Biopsy comes back, positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing.
And there was a lot of cost savings. So I actually got the bill 3 days ago, $31.76. An MRI is thousands of dollars. If something were to happen to me, or God forbid, one of my family members, it's covered.
The opportunity to take this model that DeSoto has can be replicated across the country in all these rural areas. Absolutely.
Not having to sit around that board table this year and say, okay, how much of the increase is going to go to the employees out of their pockets? I was giddy. I was excited that we did not have to do that this year.
And we deserve that. I know I do.
I get chill bumps every time we watch that video. I want to say a couple of things about that. That's patient rights advocate that came and heard about some of the work Mitigate Partners was doing in the Florida area and wanted to see if they could come film the clients. And DeSoto graciously agreed to let them come and film and share the story. Those videos, they're the group, Patient Rights Advocates, the group behind all the transparency legislation you're seeing, not the only group, but a big part of it out of the White House. And the American Hospital Association fought the transparency recently and lost. I think they appealed it, but they're the ones behind it. HH Secretary Alex Azar has seen this, and the White House has seen these videos. That's who's seen these. So it's a tremendous opportunity. There's so much we could do to help solve this rural healthcare crisis. And here's the thing I want to say real quick. Mount Everest was once unclimbable. Now there's a little problem. My buddy Hunter Schultz says that. So many people have climbed it. There's oxygen bottles everywhere. You're tripping over. So when DeSoto did this, it was the courageous employer. It takes a good advisor and a little courage, and that's the courageous employer. What Lois, Vince, Dan, Teresa, Maricela, and the whole executive team did takes guts. It was a step out from status quo, breaking away from a BUCA, Blue Cross United Signet Humana carrier. So it took a lot of guts to do it. We hopefully, Barry and I helped give them more courage to do it. And the point we want to get across is this is being done all over America. We've got 4 other clients doing this, so it's not that big a leap, but we want to commend DeSoto for doing it. Unfortunately, the way that Laura and them found out about me was from a deer stand. We did this telecast from a deer stand November 2nd last year. We won't watch that. It was 36 degrees, so I had to talk pretty quick and get it done in 10 minutes. So we also did, Dr. Gross graciously had us as a case study at his Nuts and Bolts conference in November last year. Lois and I were there, and of course, Dr. Gross, because is the DPC, one of the top DPC docs in the country. So that's a great conference. Y'all have a chance to go. It's also on a good friend of mine, Christy Gupta's podcast. It's been everywhere. It's made national news. So we're very blessed that DeSoto has been able to achieve this. Key themes today: build employer-built healthcare versus insurer-built. Take active management of your spending patterns instead of the passive managed approach you get with the BUCAs, Blue, United, Signet, and Humana. Relocalize care. Get back down to Marcus Welby MD days. Neighbors taking care of neighbors. That's what this is about. DeSoto is a great community. It's about getting it together. Focus on building community-owned healthcare. We have got to own this as a community, folks. We can't let the insurance companies own it. It doesn't work. And then maximize the local care team. Let the doctors, let the pharmacists, let the hospital, let the patient all work together. Let's put the patient in the center of the mix, not being distracted with a bunch of middlemen. And through this, you can achieve 10 times the benefits for half the cost, as we're going to show you, as already be showed in the video. There's a way to have health insurance your way and on your terms. And I apologize for my passion, folks. It's just the way I was made. I'm so excited about this stuff. The challenges: they were the 4th poorest county in the state of Florida. Per capita income of $25,406. The BUCAs were extracting millions from the community. Let me show you a picture. Look at the top 20 Fortune 500. Look at these companies. And the funny part is the companies that make the drugs, Pfizer and Merck, they're nowhere in the top 20, but all the middle people are. And Cigna, it recently jumped up from 65 to 13, 52 spots when they merged with Express Scripts. So these are behemoths, folks, and it's taking place at our watch, and they're extracting millions from our community, and we got to take it back. It was a passively managed risk. They lost obstetrics on February 18. My father was a 40-year OBGYN in Macon, Georgia. I know y'all thought I was from New York, but I'm not, I'm sorry to say. But they had to drive an hour to have a baby all over the community, not just the hospital employees. And their foreign medical spend was 79% the last 4 years. That means that the employees were going away from the hospital 79% of the time when they have a 4-star hospital right there. And that was their spend, $2.2 million, and the drug spend was $482,000. Solutions: we eliminated the middles, and we implemented the Fair Cost Health Plan. We removed the BUCA ASO model and put them with an independent third-party administrator. This is healthcare. I got this slide from Dr. Gross. That's the problem. The doctor can't see because he has to look through the insurance company to take care of the patient. Eliminate the middles. You don't have to have them. There are other solutions. Active management eliminated passive management. This is what we often see, a traditional passive plan. When we met DeSoto, this is what they had. It's easy. DeSoto doesn't know any different. This is what they've heard for a long time. Every employer we talk to has, but it's easy. The BUCA's is called InsureBuilt. They've got the plan built for you, and it's just off the shelf. What we're talking about is really, we were so frustrated, Barry and I, with the system, and we had to tear the whole thing apart and create a model that made the existing one obsolete. And that's what we did with the Fair Cost Health Plan. The other interesting thing is, you as an employer can build your plan. All you hospitals out there, you can build your plan. You can pick the doorknobs, the plumbing, the faucets, the bricks. You can build your own plan, just like a house. We start with value-based direct primary care as the foundation, which Dr. Gross is going to talk about. And we build it brick by brick, as you can see here. Obviously, the interest of time, we're not going to be able to discuss each brick, but we'll talk about a couple of things. So these bricks, not every employer wants. DeSoto has many of these bricks in their plan, but this is a custom employer built plan. Here's the key. Behind the scenes, you think this complicated. It's not. It's employer built. And that's what it's about, custom employer built. Now, from the outside to the employees, this is how it looks. But guys, no house is complete without a dog. So we want to make sure we get that dog in there. That's from our friend Vince over there. And we put signs out, you know, during the college football season. And you can see that, and got a little G there. I can't hear any laughter. And we utilize cost and quality transparency tool with direct cash pay. There was a lack of pricing transparency. Nobody knew what things cost. And the BUCAs know this. 40 grand for knee replacement, 135. Dr. Gross is going to tell you a story later. And they're doing it with your money. I don't know if I've got time for this, but real quick, 42 seconds. What if you bought groceries the way we buy healthcare?
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Okay, stop. I don't need both, just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
That's how the system works, folks. Where in America do you go out and buy something and find out 30 days later what it costs? The DeSoto Memorial employees don't do that anymore. We know up front what it costs. Also, when you have a PPO or you have a network, how are you picking your doctors? You want to see physician B, but you play golf with physician I. Physician I is a great person, and they're fun to hang out with, but they're Dr. Hodad, hands of death and destruction. You want to get to physician B. DeSoto has a tool to help them. You heard Vince mention it in the video. They wanted to get 10.5 times the benefits. We weaponized the plan design. The hospital became their own PBM. We're still in the middle of that. That hadn't been totally complete. But here's the Fortune 500 PBM shell game, as we call it. You got the employer and you got the member. I'm not real smart, but it seems to be a lot of money changing hands. They're the manufacturers. They're the drug wholesalers. They're the pharmacy benefit managers. And then they're the pharmacies. What DeSoto did is they became their own. And we're still in the process. COVID slowed us down a little bit, and one of the cartel pharmacies bought one of the other pharmacies we were working with. But it's back to the community, and we're trying to keep the dollars local in the community with community pharmacists. Plan design changes effective. We eliminated deductibles and co-insurance in some parts of the plan. 3 choices for care. 0 deductible. If they go to the Friends and Family Hospital, still a very low deductible in today's times for a 157 employee company, extremely low. And then if they go outside of that, then it's a higher deductible, 1,000, 2,000 family. They can go anywhere in the country to get care. There's no restrictions. When we first met them, there were restrictions. There are none. And I'll turn this over to my buddy Barry Murphy and let him talk about relocalizing care.
Thank you very much, Carl. Carl and I have been on this journey for about 8 years. He has come to specialize on the internal application of our plan designs and resources to make sure that our hospital clients' health plans work as well as they can. I've started to focus on the external impact you can have in your community. We look at DeSoto and Arcadia and question how big a radius can we spread their influence. And none of this can be done with traditional BUCA built health insurance, because they recognize all hospitals equally. And the employees get the same out of pocket whether they go to Orlando or Tampa or Arcadia, which is why we have to weaponize our plan designs. My efforts is in the neighborhood healthcare area, trying to eliminate these barriers between neighbors and neighbors. Why would you, as a CEO of a hospital, have to communicate with employers and cut direct relationships with employers only through the representatives of networks? It makes no sense, and it doesn't work anymore. And a very significant part of our effort is to keep dollars in the local community, as in the local pharmacies in your hospital, and keep them from going to Wall Street through CVS, HCA, and the other parts of the cartel. So this is about keeping the dollars local and opening up communications. Y'all go to, y'all pray together. Your kids play Little League together. And it's a miracle what can happen when the CEO of a hospital can sit down with the constituents in the community and talk direct sense with each other. And this is a way for you to gain prestige and influence in your community, again, without added regulation and without interference. Weaponized plan designs that encourage people to go to your facility, get you out of the collections business. Carl, next slide, if you would. So I'm sorry, go back. That was good timing on your part. So we need to engage the city, the county, the school system, and then reach out to medium to large employers with custom design health plans and truly build a community network and a community feel and keep those dollars local. Thank you, Carl.
Thanks, Murph. All right, implemented DPC quick, so we're running behind. I think everybody knows this. You don't buy insurance for things that are high probability and low cost. That's where Dr. Gross comes in. Also, thanks for your $1,800 a month premium. We got your $100 office visits covered. That's happening all over America. It's crazy. Doesn't have to happen anymore. DPC is the answer. We implemented some proprietary claim data analytics, and we implemented integrated coordinated care. So I'm going to go quick. When you look at your data normally, and this is our data analyst handles about 32,000 lives in Florida, the top 10% are driving 73% of your total cost. We did a lot of analytics when we first got hired and before we went live in January 1. We were able to drill down and look and see. You can see how the healthier people don't spend much. Here's what we found quickly. We used the BUCA data. We analyzed the BUCA data for 2 years of data. They identified 66 people that I'm going to talk to you about in a minute that can participate in this custom population health management program that DeSoto has used for chronic conditions. Within 3 months, they went to fair cost plan on January 1st, 2019. That meant these 31 people had to be identified with a claim to be identified for these 3 programs. 31 people in 3 months. That's significant, folks. The data at most of these BUCA, Blue Cross United, Cigna, and Humana, is inadequate in many cases, as we found out. So the integrated coordinated care works like this. You've got the lifestyle program, less than 5 in claims, disease management, 5 to 10, and chronic care, greater than 10. The chronic care folks have a peripheral device that has 24/7, 365 Bluetooth enabled, things like glucometers, blood pressure cuffs. And we know for a fact, and when our benefit education meetings last year, 1 employee saved their life. It really did. And these people are great. There's follow-up constantly. And once a week, Dr. Gross's office for his patients gets a fax with a readout of these readings. And that's integrated coordinated care. And also quickly, when we first met them, like every employer in the country, they appear to, there's opioid issues all across America. The group that did the analysis found that the hospital decided, hey, we're good. Let's see what Dr. Gross and Dr. Crouch and their team can do. And we had the data analyzed. Vince and Lois don't even know this. About 2 months ago, and there's nothing there. I mean, it's fabulous. A total turnaround. Dr. Gross, Dr. Crouch deserve a lot of that credit for the work they've done. We also do benefit education meetings, open enrollments. We go down there and do about 6 meetings. It's tiring, but you can see I'm like the Energizer Bunny. It's fun.
Most important.
All right, you don't want to see that. You heard enough by now. So relocalize care, get back to neighborhood health care. They saved about 58% or $150,000 in their stop loss premiums. And they had 10 times benefits for half the cost, reduced the foreign medical spend to 62% from 79. That is significant, folks. People who worked at that hospital for 25 years never had care in there. Now with no deductible, we broke the barriers to care. They're taking care of themselves. Dr. Gross and his team is doing a wonderful job helping. Hired the first full-time surgeon in county history. They had a rate decrease on their stop loss premiums. Did I hear that right? A rate decrease? Second ever in the history of the stop loss carrier. And the savings, 1.2 million or 54%. I think it speaks for itself. Real quick, 3 months on the BUCA plan. They had to start, we had to finish out 3 months on the BUCA plan from October 1st to December, and 7 months on the fair cost plan. That's the difference. Barely spent more money in twice the amount of months. That's how significant that middleman can be. And then that's the printout. Then you saw this earlier, the savings, and I've got to wrap this up. I went way over. So lastly, hope and luck hitting the strategy. It is possible. It takes good advisor and a little courage, and that's that courageous employer like DeSoto Memorial. The leadership and everyone deserve all the credit. They're fabulous people, and they have been so great to work with in doing it. Thanks for your time. Healthcare's fixed. Join us to replicate the fixes. And Dr. Gross, I'll turn it over to you.
Thank you, Carl. So in the 2 minutes I have left, in conclusion,
You're good. Just go.
let's see here.
We got started 5 minutes late. I want to go on record.
All right, so hopefully everyone can see my screen today. Hello, my name is Lee Gross. I'm a family physician here in Southwest Florida. I've been in practice since 2002, and the name of our company is Epiphany Health. And in fact, we did have an epiphany, and the epiphany was, why are we using insurance to pay for primary care? Why are we using a very impersonal insurance product to pay for and interact with every single aspect of healthcare delivery? It makes it very impersonal, makes it very cumbersome, and quite frankly, it makes it very expensive. Let's see here. So if you're trying to put everything into a box, in a healthcare box, and you're going to call that box insurance, you're going to put your affordable primary care in with all your end-of-life care, your bypass surgeries and everything. What it does is it artificially raises the access price to primary care. But if you split out the primary care from all those cost drivers, it actually makes primary care very affordable. And so this is an example of how insurance makes something that's very easy, very complex. This is a toothbrushing machine. What direct primary care does is it splits out all that noise and allows the doctor and patient to be the only people actually interacting in that room. It strips out all the middlemen from that equation. What we effectively did was create a Netflix type approach. It's a monthly subscription-based primary care practice. And I'll tell you what it costs in a little bit, but the approach essentially eliminates fee for service that allows insurance to be an insurance product or a hedge against a catastrophic loss, with a clearly defined package of services so that people know exactly what their routine care costs. It has complete price transparency, and what we quickly realized when uninsured patients started coming to our practice from all over the state of Florida, that we needed access to affordable labs, affordable imaging services, affordable physical therapy. And effectively what we started to do was reach out to our local community and build a network of cash-based transactions that people knew exactly what services cost. And I think you'll be surprised to find out what those things actually do cost here in a minute. But anything that can be done in our office is included in our membership fee at no additional charge. So colon cancer screenings, EKGs, joint injections, steroid shots are all included. The price for that is $65 a month for an adult and as low as $10 a month per child. And after that, we don't charge any copays. We don't bill any third parties for any services done in our office. So I can do a skin biopsy. I can drain an abscess. I can fix a laceration. If you start looking to what sort of prices we were able to secure for our uninsured patients in the community, we were getting CT scans for about $175 to $200, MRI costs for about $220, among the cheapest in the country. A chest X-ray, just a little over $20 for a cash base. That's, people are paying more for a copay to get those same services done. So just to kind of put it in perspective, this is an actual hospital bill of a former patient of mine that went to the emergency room with abdominal pain. I show this because this is actually the real bill, but I'm going to show it in the next screen, where that hospital charged $20,000 for an ER visit for abdominal pain. If that patient came to our practice, we had the same exact tests done, seen a physician, probably we can see our patients same day, we can order stat studies, so sometimes it's even quicker than the ER. Our patients pay out of pocket for the same services $301.29. That's the actual cost to the patient for the services. So we've actually had a case now where we have had inbound medical tourism into the United States for a patient that couldn't afford care in the Caribbean. This patient had thyroid cancer. That person in the upper left-hand corner is Dr. Elena George, an ear, nose, and throat surgeon friend of mine from Atlanta, Georgia. She does mission work in Antigua. Diagnosed a patient down there with thyroid cancer. And it was $100,000 for her to get the thyroid cancer treated in San Juan. And so through the work of my friend in the left lower corner, Dr. Keith George of the Surgery Center of Oklahoma, he reached out to me and said, you know, hey, this patient really needs 6 months of pre-op and post-operative medical management. Can you help me with that? And so collectively, we did all this. She came to the United States. She saw me. We staged her cancer. We had all the imaging. We had an endocrinologist. She flew to Oklahoma City, which we coordinated. She had her surgery, came back, and we did all the post-operative management. The total cost was $10,000 for her. So we saved her $90,000 and effectively her life, because at $100,000, she was not having that done. So fast forward, that brings us to, how do we know DeSoto Memorial Hospital? How do we come to get together? Well, DeSoto Memorial Hospital, Vince Sica, visionary CEO that you're about to hear from, reached out to me and he said, hey, you know, I saw your presentation to the Florida governor and I really liked what I heard. And I think we can do some of these cash bundles here locally. Would you be interested in working with us to do that? And so we worked together with his team and put together bundled surgical cash prices, transparent cash prices. And you're about to talk to one of the first hospitals in the country that actually has open and transparent cash prices bundled for surgeries. So uninsured patient in Florida might pay $45,000 to $60,000 to get a knee replacement surgery. They could do medical tourism to Singapore for $18,000 to $22,500, or they can go to DeSoto Memorial Hospital and pay $18,550 bundled, including the implants, the hospitalization, the surgeon, anesthesia, and everything. I point out the skyrocketing cost of healthcare to show that our membership prices have not gone up since the day we started this 10 years ago. I can tell you that the prices we're paying for medical services on behalf of, or that our patients are paying, our negotiated prices effectively have not gone up in a decade. So when the opportunity came to work with DeSoto Memorial Hospital and got to know them, we had the opportunity to introduce them to Carl and redesign their employee health plan exactly as Carl said, using the direct primary care model as the foundation of that. And so Carl already showed this picture where we spent a lot of time working, but this is our 1-year data. So the hospital plan design allowed the patients to choose the direct primary care, or they could do their traditional fee for service, stay with their doctor. They did not have to choose us. And so we actually have a comparison arm built within the model. And so 59% of the hospital plan, or the hospital employees that were on the plan, participated in the direct primary care practice. But when you look at the total number of family members, you can see that only 47% of the plan members or the family members were in there, which means that since we only see kids ages 5 and up, the larger families with smaller children actually chose the non-DPC. So you can actually see the average family size in the non-DPC group is quite a bit higher, reflecting a younger population in the non-DPC group. And effectively what that does is it translates into more chronic conditions within the direct primary care group. And you can see there was about 35% more chronic conditions per body in that direct primary care group. So we actually had a sicker population. This is, you can see on the top line, the medical claims, the DPC, $114 per member per month, compared to the non-DPC of $99. And you look at that and you say, well, wait a second, that's not cheaper, that's more expensive. Well, first of all, I'm going to point to that far right-hand column. The national benchmark for those services were $450. So even the non-DPC group was blowing away the national benchmarks. But when you adjust for the chronic conditions that were in there, and you start talking about how effective it is to care for sick employees, there was an 18% favor in favor of the direct primary care, a 16% in favor of the direct primary care in terms of pharmacy benefit claims, and about a 17% overall spend. But then we want to break it down into a little deeper dive into where that money was spent. And if you look at line number 2, we're looking again for the DPC column, that $114 in medical claims per member per month. 73 of those $114 were spent in the hospital itself. So Carl talked about that 79% foreign spend. We're basically 64% domestic spend within the DPC side. You look at the non-DPC side, and a lot of that money is going out the door to other companies. So when we talk about a hospital as the insurer and a hospital as the care provider, $73 goes from the hospital's right pocket to the hospital's left pocket. That's how important that number is. So that $114 spend, you effectively cut that number in half. So we actually had a 49% benefit to the DPC side. You look at a 31% reduction in emergency room claims because the DPC practices are so efficient at getting patients in, getting them cared for, and getting on top of things before they actually become emergencies. The biggest number here is a 60% reduction in specialty consultations, a 60% reduction in specialty claims to the plan. And the membership's total out of pocket was a 27% lower in the DPC group. So effectively what we did, looking at Carl's numbers, is we had a $1.2 million reduction in claims. I didn't even mention that we actually gave the employees a reduced 20% premium in the DPC arm. And so they saw 20% immediately reduction in their premiums. We eliminated through the direct primary care all co-payments and deductibles for all their primary care service. So there were zero barriers to access to care whatsoever. And in the process of doing that, in the process of limiting obstacles to care, freeing up the physician to actually be a physician, we reduced the employees out of pocket 30% and a total 54% reduction in the plan. And I can tell you the one thing that's really, truly wonderful about this plan is they really did free up the physicians to be physicians. Carl, in the plan design, and the hospital leadership in this plan design have effectively said, if the direct primary care practices order these services, they're covered. You don't have to do the step edits and prior authorizations. We have vetted the specialists that we refer to. So if we make a referral to a specialist, there's no need to get on the phone and fight for things. They don't pay people to oversee their physicians. They trust their physicians, and that's why they hire their physicians and work with their physicians. So it has been a wonderful experience on our part. It's been truly a blessing to work with this visionary team. All of these people here are very special and brave people, and I have truly enjoyed working with every one of them. So with that, I will turn it over to the other folks.
Thank you, Dr. Gross. Great job. Again, I don't think any of us would argue the DPC has been the biggest part of this plan, without a doubt, hands down. All right, Vince Sica, CEO, Lois Hilton, Human Resource Director. The folks that have to put up with me, and they like putting up with Barry, they struggle with me. Take it away. Are y'all there?
I think we got to unmute you guys.
Oh. Anybody there?
They need to unmute.
Yeah. Okay.
There we go.
All right, how's that?
There we go.
You now sound as good as you look.
Thank you.
Take it away, Vance and Lois.
All right, well, thank you very much for this opportunity. This is one of those things that we've actually worked on for several years. I met Dr. Gross, and as we put things together, and I, think that the direct primary care is, it's probably as innovative and a program as there is, and it truly, when you think about, just do the math on what one office visit costs under a regular circumstances compared to $65 a month, and you have, total access to your physician, truly 24 hours a day. It's just incredible. And then when you factor in the fact that you can save money for the plan and save money for our organization. And, DeSoto Memorial Hospital, we're one of the few independent rural hospitals in Florida. We're a hospital district, so we have a 5-member board appointed by the governor, and we have 2 community members, so we really have what we call our 7-member board that we report to, and that we believe that we're a vital part of the community. And I think the fact that some of the things that Carl related demonstrate that. Overall, this has been a significant area for us in that we've reduced our expenses significantly, and I truly believe it's a better plan. There's not one employee that has been dissatisfied with the direct primary care program. Not one. And that's a tribute to the care that Dr. Gross and Dr. Crouch provide for our employees. I can tell you that there was one that had an issue with opioids, and Dr. Gross worked with him on a day, almost an hour-by-hour basis until this person was, to a point where he could handle it by himself. And that's a tribute to the kind of doctor that Dr. Gross is. I actually call, Dr. Gross is a friend, and he's a friend to everyone, and he's great for our community. But, as we move through some of the things that we've done, the numbers speak for themselves, and Carl has done a really good job of expressing those numbers. The things that I like to talk about are, the innovative things that we did. I think the medical advocacy program is fantastic. We can talk numbers with regards to, I know that some of our ladies had delivered babies over at Sarasota County, and normally the cost of that is in the $30,000 range. The cost to the plan is in actual dollars is around $30,000, and a result of the when we were with the BUCA program, and as a result of what we've done with the medical advocacy program, that cost to the plan was reduced to $8,000. I can tell you specifically that one of our employees had a heart catheterization with stents. If you look on the Florida Hospital Association transparency website, which is called missiontocare.com, at that hospital where the procedure was done, their normal charges are $129,000, and the average payment they receive from the insurance companies is $30,000 to $35,000, and our plan paid $13,000 for that procedure. And so, those are the kind of significant things that, we can support with this plan. Carl's done a very good job. We've had to teach him to spell correctly because he still wants to spell dog, D-A-W-G, when it's, here in Florida we spell it D-O-G. And so we're very fortunate to have been working with them. You can see the chart, but it's one of those things that we're trying to get it out to the community. We've had discussions with the county and the city and the school board, and we're going to continue to pursue those. I will tell you that probably the COVID pandemic has probably held up everything a little bit because of those activities, but we're going to continue to pursue this. It's the right thing to do. If anything, it's the right thing to do, and it's important that we provide these opportunities and demonstrate to the public that we can change and there is better ways to do things than just paying a premium every month and let them take care of everything. It's sort of I'm from the government, I'm here to help you. Well, that's not true, and the active management of this is key, and Lois and her staff have done a wonderful job. So I will turn it over to Lois and let her explain the impact on what she's done.
Thank you, Mr. Sica. Good afternoon, everyone. And I'll just take a few minutes and talk about from an HR perspective and from the employee perspective. You've heard all the numbers from a fiscal, component, but I will tell you that when we implemented this plan, I had my concerns as far as how the employees were going to respond to it, because what we have actually done, as Mr. Sica said, we have gone from a passive plan as far as like, here's your insurance card, go get your care, to an active management plan where we're actually helping the employees make better healthcare choices for the right reasons, making sure that they are going to physicians through that medical advocacy program to where they're going to the right providers, right facilities that have, better outcomes, low infection control rates, how many procedures have they done, and they also look at costs. I think it's like a five-pronged area that they look. So we decided to incorporate a product and build our employer plan, as Carl was saying. We decided to do that so that we could have the employees actively engaged in selecting who they want to go to for their health care and making some choices. So utilizing that, I will tell you that was the challenge with employees because they previously had not been having to make those, doing that homework type of thing. But now for any elective procedures, we ask our employees to do a little bit of homework, and we help them with that, and it has been very rewarding. And we are now a year and a half into this program, and when we did our open enrollment, I anticipated the employees kind of talking about how much work they had to do to be part of the program and all of that, and there were no complaints. There were positive comments on how much they liked it. Because the employees, we were very open and honest with them in how being self-funded worked, how much it was costing the employer, and in turn, how much that was costing the employee. Because as we explained to them, your copay and deductibles was the same whether you went to a facility that charged $25,000 or $50,000 for the same procedure. Well, when we actively educated everyone and explained to them and got in the weeds with them about stuff, the light bulb went off because, being a rural hospital, every penny counts to us, as with a lot of you guys. And so when we explained to them that by them helping us being actively engaged in making selections and right choices for their health care, saving the facility money in the long run ends up affording us to be able to provide them with great benefits, to be able to provide, that we can put it back into the facility, back into maybe, into wages and, equipment and things like that. So it was definitely a win-win. I will tell you, it does take a lot of engagement from your HR team, but I will tell you that it has been the most rewarding. I've been doing this for over 30 years here at DeSoto Memorial with the employee benefits, and it has been the most rewarding year and a half that I have had engaging with our employees on their active management of their health plan. And our employees are happy about it. And as Vince said, the DPC program, the Direct Primary Care Program, has been a huge, huge part of this. And those of you that are in healthcare, which is most of you, understand that healthcare individuals, nurses, x-ray techs, lab techs, they're all very critical of their providers. A lot of them do their own self-diagnosing and all of that. And I will tell you that we increased into the second year. I think we increased over 25%, 30% maybe of the folks that went into the direct primary care because they had heard such great things and had testimonials from employees of what great services and engagement and relationship that they had with the direct primary care folks, with Dr. Gross and Dr. Crouch. The direct primary care model and being in a rural area goes hand in hand as far as I'm concerned, because we're here for our community. We do what we can to help our community, and direct primary care, I feel like I've gone back in time, with the old-fashioned physician that sits with you and spends time with you. And, it was a win-win situation. So not only has the plan saved money, as everyone has talked about, but then the employees also have saved money by being able to use the direct primary care and not having to go to all those specialists, because the regular doctors don't have time to speak with them and say, you know what, I need to send you here because I've got, 2 more patients I have to see in this 15-minute slot. Whereas with the direct primary care, you get a 30-minute slot. So, it has definitely been a win-win. The ability to negotiate cash prices and the price transparency that Mr. Sica and everyone's been talking about has been huge. It has been eye-opening to us, even though we're a hospital and we know the dollars and the charges and that type of thing. But as far as going out and utilizing the medical advocacy program where we can negotiate some cash deals for a scheduled procedure, the employees are just very thankful that we were able to, number one, save them dollars at the same time as saving the plan dollars by doing the cash deals. So it does take some active management, but I will tell you that we have a phenomenal team with the Mitigate Partners and FairCo partners, with Barry and Carl and them. The TPA, we did hire a third-party administrator to pay our claims to keep us legal. And we have a phenomenal third-party administrator right now that works with us and that is actively engaged. 8 o'clock, 2 days ago, my phone was ringing at 8 o'clock, and it was the third-party administrator going, hey, I need to go over a couple employees with you if you've got some time, and just drilled down. And instead of waiting for the employee to come to me and go, why didn't the insurance company pay for this, the TPA called me ahead of time and was actively engaged. So I will tell you that the team that we have between the direct primary care and the third-party administrators and the pharmacy, it's all been a phenomenal relationship. And as I said, I have never been more excited and just so thrilled to be a part of that with our employees. And they are very, very happy and engaged with this. So I do not regret our facility going in this direction. I would recommend it to anyone, but I'm not going to sugarcoat it. It is a lot of work to the HR team, but they have, if they're on board and they have that positive attitude and can watch those employees go, yep, I know, let's make this phone call, we'll do it together, or this is what you need to do. And the first 6 months was pretty intensive, but I'll tell you now this year, not so much, because all the employees are now engaged in it and that type of thing. So very, very happy with the product, and not only from an employee and an HR perspective as far as providing to the employees, and because I will tell you that we are in an area with a lot of rural areas where more than 50% of our clinical people drive into Arcadia. They go, they come from the Sarasota, Fort Myers, and, Port Charlotte area, so they have to pass all those other hospitals to come to us. So recruitment is a huge factor for us. So this plan has been very effective because it also allowed those folks to be able to keep their external primary care physicians, and it's a win-win. So I would encourage any of you to look into this and research it because it is such a great product for the facility from a financial aspect, and then also from an employee-based perspective.
Anyone that would like to talk to us further, Carl, if you can, you're more than welcome to distribute our contact information. You know, my direct line to my office is 863-494-8403. And certainly I would be happy to talk to anyone regarding this. It's truly been a really good thing for us. And, you know, it just shows you what you can do, you know, and then, you know, people are smarter than you think they are. And that, you know, everybody knows that 20% of a smaller number is a smaller amount that you have to pay. And and I think in the past, the employees were never told what a procedure had, the effect it had on the plan. And so when you explain it in this matter, it's sort of, okay, we're on the same team. You know, certainly you can go anywhere you want to have a procedure done, but, you know, if it's going to cost $20,000, and that's our cost, $20,000, and your 20% is $4,000, or you can go to the same different hospital or a different location and get it for 10, then your 20% is $2,000, and the quality in safety is the same or better. Then it makes really good sense, and people understand that and are willing to take that extra step. You know, I'm very happy with the program. You know, I'm part of the DPC program, and I can tell you that I text and get prescriptions filled. I send pictures of a rash I had on my neck, and I got an answer on what to do. And that, you know, and I know it's not just because it's me. I think that's what Dr. Gross and Dr. Crouch provide. That's the service they provide to any one of their patients that's involved in the DPC program. And you know, Dr. Gross has fought for years through the state and national organizations to get these concepts. And it makes perfect sense when you think about carving out the primary care, because you want people to use primary care, especially before they get sick. But then when they are sick, you know, how often have you called your normal doctor and he says, okay, well, I can see you 2 days from now. Well, you don't need care 2 days from now. You need care today. And so it's been really worked. And, you know, Carl has provided us with a lot of extra partners, I would think. Aether, who's the TPA, the MAP program, the pharmacy program, they're all integrated, and it's really, really helped us. And so I'll be quiet now. And so thank you very much for this opportunity. And like I said, I'm very passionate about this, and anyone that wants to call me directly or email me, feel free. This is really a good plan, and it's good for everything. It's good for the country. It's good for your local communities, and it works.
Well,
thank you for the opportunity.
It covers dog bites.
Yeah, man, that's exactly what I was going to say, man. She said I wasn't a dog, they got a hold of you. Barry and I want to, and Dr. Gross want to thank you guys, because, again, without you being the courageous employer, none of this matters. And you took the step. I think to put a bow on the whole thing and to really sum it up, let's hear from one of the employees and listen closely to what they say and how they were scared to use their plan. And we'll close out and hopefully have a few minutes for a few questions.
Well, the benefits that we have here at the hospital are more so focused on the employees. The latter part of August, I had a concern regarding my neck, and I went in to see my primary care, listened to my concerns, and he recommended certain protocols. It was my choice of what I wanted to do. You would think with the specialist, the appointments are so far out. Within maybe 3 weeks from seeing my primary care, having my test done, getting my results, finding out that I need to have a biopsy done. Biopsy comes back positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing. So before, I was paying all that money on my premium, and I never used the plan because I was reluctant. Because of, okay, I have this copay, I'm going to have this deductible. We don't have those issues. Every concern I've had since day one of this plan, I have addressed and have taken care of this year. And I've paid absolutely nothing out of pocket. And we deserve that. I know I do.
I love that gets me every time. Thank everybody. And I just want to say one thing. You heard her say benefits are for the employees. In most companies, benefits are done to the employees, not for them. Big difference. DeSoto deserves a huge round of applause for all their hard work. I mean, Lois, Lois and Vince have to put up with me, and that's terrible. It's been a great relationship because George has owned the Georgia-Florida rivalry, which we've enjoyed a lot, at least on my side. But they are great partners, and we're just so thankful to have them. And guys, there's 126 rural hospitals that have closed since 2010. Don't become the next one. And President Trump just issued an executive order earlier this week on Tuesday for the rural health and telehealth access. I know that Dr. Gross was very involved with that. So those are the kind of things that are out there, and we'll open it up for questions if anybody's still with us.
Thank you, Carl, and thank you to all of our speakers. We understand if people have to drop off because it is one, but we do have some questions in the chat that I'll read out, and any of our speakers can chime in. I believe it was Zeb that asked, what if we do not have DPC here in Western Mass to integrate in our local community? The only other thing we have done is virtual primary care with a third party. Any thoughts? How do we get a group of physicians to flip? I only have about 500 members in the area.
Dr. Gross, you still with us?
Yeah, so through the work of our foundation, we receive grants and travel around the country putting on conferences for free to teach physicians how to start their own practice. And so across the country this far, we've trained over 1,000 physicians nationwide on the practice model. And we have grown from about 10 independent practices in 2010 to about well over 1,000 practices now. So it is coming. So if you go to the website of our foundation, it's d4pcfoundation.org. You can actually see some of the free content there. If you have a physician that's struggling, about half of the primary care doctors in the country right now are near insolvency due to the COVID crisis, because when you cut off fee for service for the doctors, you cut off the revenue. We are in a growth mode in our practice. We're actually hiring. But I think, Carl can probably speak to how he's done some of this in communities that did not have DPC, because I think that's an issue, he's run into as well around the country.
Well, I would comment in Southeast Georgia, we partnered with a hospital who does have a couple of hospital-owned physicians, and we've talked about establishing a DPC type of a platform there. And we're at the very beginning stages of talking to federally qualified health centers, which are run, semi-government grants, about setting up a DPC type of a platform, not only to integrate into the essential health plan of the employers in the region, but as a model for the employees who can't afford the insurance as it's structured, but still need access to primary care.
It's hard. I mean, there's so many great, you got Dr. Gross, who in March of 18 went and got his own state. He worked on it for, I think, over 6 years to where DPC wasn't considered insurance. Dr. Ayai, Dr. Shane Purcell, Dr. Gold, Dr. Umber, there's so many, Dr. Corba, Dr. Lindley, there's so many great DPCs that have led this, and Dr. Gross is so generous with his time. Can't tell you how many Saturday mornings he and I've talked, and he always tries to rush me off the phone. I don't know why, but anyway, and he spends time with other people that are interested in DPC and does that. So his conference was awesome. There were over 400 DPC docs there. Lois will tell you. I think Lois's knees were shaking when she stood up to speak. There's a lot of people. So he does so much good stuff for everybody. And there's DPC mappers, DPC Frontier, and DPC Alliance that you can go to and look at the closest DPCs. But we're trying to do some things with a community pharmacist down in Okeechobee, Florida right now, and she's probably on the phone, or probably on this webinar. But we're trying to do that exact thing. I already talked to Dr. Gross about it this week. So it can be done. It may take a little bit, but you've got to get those employers to move away from this insurer-built healthcare so that you can insert DPC in. Because if you put DPC in an insurer-built plan, the insurance company's not going to give you any credit. I can't say enough nice things about Julie Boback, Olga, and Christy Vago at One Beacon, our stop-loss partner. They discounted the premiums 58%, folks. This is 157 people. $150,000 discount on their stop-loss premiums because of DPC and fair cost. So that's the one thing message I would leave you. You have to do employer-built healthcare to get the credits for all of Dr. Gross's great work. And it's proven out. It's absolutely proven out. Not to mention the improved clinical outcomes. I'm sorry, little passion. Laura, any more questions?
We have a question. Yes, we have one from Hunter Schwartz. He's saying to Lois, looking back, what would you do different? Oh, sorry, pop up. And what consumed your time the most? Oh, Lois, question for you. We got you muted. There we go.
This is from the Winning Healthcare Food Fights person.
Oh, Lois, we're not hearing you just yet.
Okay, now can you hear me?
There you go. Yes.
All right. Okay. Would you repeat the question again?
Sure. So the hardest hurdle, hold on. Ooh. Looking back, what would you do different, and what consumed your time the most?
Looking back, I probably would dedicate a lot more availability for employees to come speak with me one-on-one, especially when it comes to their personal needs. And I would say that probably is what took the most of my time, was educating people on how do they navigate the system as far as being actively engaged in choosing the provider. Because as we built our employer plan, we had network, and we drilled our network down, and that helped save money as well. But as Carl said, they could go anywhere. So probably just making sure that we could provide enough one-on-one time, whether it be by phone or in person, to the employees to kind of go through their first time that they had to walk through the system. I probably would have spent more time beforehand as well. So.
One of the things I would add to that is the education component is somewhat time consuming. So we have patients that might need to go see a specialist, and they say, well, I can't go see my cardiologist because he's not in the network. And we say, well, no, you can go anywhere. And it reminds me of the story, like an old horse that spent an entire life with a fence around it, and you take the fence away and the horse still stops at the fence line. And you say, well, be free, go anywhere you want to go. And just trying to push them out over that fence line and teach them that they actually can, they have total freedom to do whatever they need to do. Now, the plan does put financial incentives in place to make sure that they're choosing wisely, and gives them an advocate. That MAP program make sure that they're navigating this complex system with eyes wide open, and it's actually been very effective in that regard.
And I would say this, most if not all of the programs that we've engaged with and put in, there's ample savings to hire or elevate an existing employee to a function we call the benefit champion. Carl, you want to comment on that for a minute?
Sure. We, certain groups, depending, Lois has had such a good team, we didn't do it there, but Hotel Gas Berlin, about an hour away from DeSoto. By the way, they have a
school district.
Do what?
In the school district.
Yeah, in the school district. And by the way, DeSoto has a direct contract with our client. DeSoto was more than willing. They have about 20 employees that live in Arcadia. So Benefits Champion is the mother hen of the group. Liz Rock does a great job over there at DeSoto. The school district of Osceola County, about 9,100 belly buttons, is putting in a couple of Benefits Champions. And those people's sole job is to work with the member on benefits, not do payroll, not do HR, because no one could even come close to doing Lois Hilton's job. She's the best. But that's all they do. And they're there to help direct the member and navigate through the programs we have. And that's a vital role if we can do it. And the money we save generally, funds it.
One of the hardest things, and Carl, you're probably being kind, and was that getting the information on our employees from the prior TPA, which was part of BUCA. And that took a lot of time and effort for us just to get that information, and it was our information.
You even had claims denied for your own hospital.
Yeah. Yeah, when we started with Vince, he goes, "Hey, Carl and Barry, we're having our own members denied claims at our own hospital from the BUCA." So pretty crazy mess. I want to also say something about Dr. Gross and Dr. Crouch and any DPC in America. These are not normal doctors. My father, again, 40-year private practice OBGYN. My dad didn't go, "Hey, Lois, everything looks great at this checkup. We might want to get a sonogram done here or an MRI." He'd say, "Go down the hall." Well, down the hall in a lot of these places is marble floors and granite countertops, and it's not inexpensive. And so Dr. Gross and their team and these DPC docs are a consumer with you. So there's no down the hall mentality. I think that's very important, very different, and they worked out deals with other physicians in the community. And the other thing is, you want to go find out where the good care is in a hospital, you talk to the nurses and the other doctors. And Dr. Gross and Dr. Crouch know who gives good care down there. And so they helped us also assemble and build our DeSoto's employer-built custom network. They had a big role in that. And like we said, we've approved those doctors, great quality. So I wanted to make that statement.
So we have some other questions in the chat. Christy and Kayla both want to ask Lois, the hardest part as an advisor, Christy says she has, is to jump over the HR department. What advice would you give your fellow HR professionals out there that would help them open up?
Great question.
It is a good question. I'll tell you, it took, a year, Carl, for me to finally go, okay, we're going to try this. Mr. Sica, our CEO, was ready from day one. And from an HR perspective, we know how much work is involved in this type of stuff. And it's also, we're here as an employee advocate as well, making sure that our employees are satisfied with the products that they're getting and educated about it. And because this was a new concept, it was pretty, it was a big jump. And I will tell you that I regret taking that long to make that move. I wish I had listened to our CEO and said, let's do it and move ahead. But my CFO and I, we just kind of kept plugging along, kept researching, kept talking, kept, analyzing everything. And it works. It truly, truly works. And that's what I regret, is waiting and not implementing this.
Hey, Lois, quick question before Laura asks another one. That custom built, plan that we worked with you guys on, that meeting, I think people ought to know, because you got to feel for Lois and Vince. I think Vince fell asleep a couple of times during the meeting. But it was on October the 1st, 2018. We sat down for 5 hours from 1 in the afternoon to 6 at night. We had our stop loss partners there. You just heard Julie and Christy, Julie Boback and Christy Vega were there. We had our cost and quality company there. Dr. Gross was there. And I'll never forget, quick story I got to say. So Dr. Gross, you're going to have to submit $0 claims so we can see what's going on with the member. Boy, I could have driven a Mack truck in his mouth. But he did it, and that's the data he has and the proof in it. And we appreciate it, because it was a burden. He left that world to avoid that kind of process. But I think we made it pretty easy. At least I'm going to say that. Maybe not totally true. But Lois, when you built that house, that dog really topped it off, don't you think, in that second story? I mean, that was what was best about it, right?
Well, I think that was a pet gator that was up there, but anyway.
Yeah, relentless.
No, but building it, I will tell you that it was the first time we've done a lot of plan, and it really opened my eyes too. Is that we did build this plan as a team with the TPA, with Dr. Gross spending his time that afternoon there, with the reinsurance carrier. I don't think I've met any of our reinsurance carrier reps until that day. And for them to sit at the table and listen to how we were building the plan and how we were implementing all of the safety measures for employees, for infection control, and the whole 9 yards. And then for them to come in with that reduction in the cost was amazing. So I will tell you, while it was a time-consuming event, it was very, very worthwhile and very rewarding. So that was good.
Yeah, also, instead of picking from A, B, or C, the ability to customize in somewhat granular detail, I would suggest for the first time you knew why your plan was designed the way it was, and it wasn't just, well, that's the way we've always done it. We talk about weaponizing the plan design because it doesn't make a lot of sense for an employee to have the same out-of-pocket for a $150,000 procedure that they could get elsewhere for $45,000.
Correct. Correct.
Go ahead, Laura.
Christy said in response to your comment, Lois, she said, well, thank you for being so courageous. Zeb says, make sure you have the right TPA support, get buy-in from the top down. Everyone needs an educated and communication needs to relieve the burden from HR, just my opinion and professional experience. Then we had another question. How can we make this easier for the employees?
Educate, educate, educate.
I will tell you that, yes, I agree, educate. And the one thing that I realized, because now I still am one of the old holdouts when it comes to open enrollment. We meet with our employees face-to-face, and I go over and spend, 45 minutes to an hour on their health plan and how impactful it can be to them and what a great product it is for them and their family if they're getting family coverage. And so I just lost my train of thought.
Yeah. How do you help with how do you help the employees?
Oh, and as far as with the employees and that type of thing. So as far as them getting educated, it's truly, truly rewarding when they learn about how the plan works with them. So they don't mind making some of those phone calls through the medical advocacy program and that type of thing. And so and I know where I was going. And so what I learned was that I give them examples. So say, for example, and I'll walk them through how that would work and how it would look from the day they would make a phone call to MAP and walk them through and how all the responses are until the end and how we would work together as a team and how all of the players play out, from when the claim gets paid and that type of thing. So once I give an example of how that is, you see the light bulb go off and they're going, oh, okay. Because until I learned that until I gave examples during those open enrollment in meetings for new hires, they really couldn't see how it worked. But giving that example and walking them through the step-by-step and having the sheets in front of them going, this is what this means and all of that, and they're like, okay. So, it's kind of, you show it to them and they get it because they can't visualize it when you're talking about it.
Yeah, I want to point out one last thing before I'm going to have to hop on off here in a minute. But when we talk about the savings that this plan generated, I just want to make it perfectly clear because we sort of hinted at it, but this plan was already self-funded. Okay, so it's not those savings were not going from a fully insured plan to a self-funded plan. It was going from a self-funded plan through a national carrier TPA through a self-funded plan that was custom designed and eliminating barriers. So what we didn't mention is if any employee gets anything done at the hospital itself, there's no cost to them. If they get surgery, it's free. If they have an MRI, it's effectively free. If they get blood work, it's free. And the 1.2 million savings was with unleashing these patients, not by putting up barriers, but by reducing barriers.
Good point.
One thing to thank you, Dr. Gross. One thing to follow up to, one of the courageous things that DeSoto did is not every employer will do this, but what we decide to do to protect the member, the employee, is if they're having an elective or pre-certed procedure, they're required to call the cost and quality company. If they don't call them, they'll be penalized. And you can pick your poison. We used 1,000, but that right there in itself, everybody, I remember when we educated them, they freaked out. But what we said is, all you gotta do is make the call. And if you want to go see Dr. Schuessler, even though Dr. Schuessler is Dr. Hodad, and you don't want to go see Dr. Murphy, then your plan is going to work like it always worked. But if you go see Dr. Murphy, with that the nurse navigator suggested, then maybe a deductible, if there is one, there's not one in a lot of these plans as y'all saw, or a copay is waived. So that was a big thing that DeSoto Memorial did with Lois's leadership in that events, and Dan and everyone. Not every employer will do that. And I will tell you, that's protecting the member. That's protecting them, because my dad's C-section rate was 15% his whole career. There were doctors in Macon, Georgia, whose C-section rate were 50%. I'd like to know if my wife's going to get cut open half the time versus 15% of the time. You can't find that out, and that's the information that these guys help us with. All right, I'm done. Go ahead, Laura.
We've got a lot of questions or a lot of thank yous. Fantastic session, everyone. Been aware of this marvelous solution for a while now, but always encouraged to hear about it again. Christy, we will make this recording available, and so you can, distribute it with your
hey,
people
Christy,
you'd like to share it with.
Christy needs to be charged for the recording. I'll set the price.
You can handle that, Carl. And we have a question. We shouldn't really entertain it, is give Carl too much. He said, how many days has it been since Georgia won? The Bulldogs won a national football championship, but we won't get into that. He said, that was Tyler.
That's Tyler Emmons, DPC doctor of Ocala, Florida.
He said, thank you everyone for sharing. Will you please, and she said, Christy said she'll pay anything for this recording. So there you go. You got an open window, Carl.
Is that Gupton or Vago?
Gupton said that. I'll pay anything.
That's Christy's quote. All it takes a good advisor and a little courage.
Well, thank you so much for joining us today. Thank you to our speakers and our participants. And we will send this out as a recording and make this available to you. So thank you
Laura,
thank you very much for having us.
Yeah, thank you. Thanks, Vince and Lois. Thank you guys for putting up with us. Y'all are a great partner, and Dr. Gross, wasn't for you, we wouldn't be here. And Barry and I are just so appreciative of the opportunity to work with all you fine people. And Laura, thank you for having us on here as well.
Thank you. Everyone have a great afternoon.